I'm Ruth Meadows and I'm the Assistant Director of Nursing for Children, Women, Critical Care and Outpatients at St George's Hospital in Tooting in London. We have at our hospital something called a Children's Council because we're very conscious we wanted to ask children what they thought of their care. There was one particular young girl who was about 12 who was very upset indeed and was with her mother. When we went to meet with her to find out what the problem was, she told us that she was absolutely distraught about being in a bed opposite a boy of her own age. She had a urinary catheter in place, she was bedbound, and she was mortified that she was in a bed opposite a 12-year-old boy. We were really quite distressed that it hadn't even occurred to us that this would be something that would be so traumatic for her. It was very easy to solve. We managed to reassure her straight away that it wasn't a problem and that we could move her to a place where she felt much more comfortable. We went back to the ward sisters and to the ward staff to explain what we'd found, and we looked at how we admit children and how we actually try to reassure children and look at all the issues we have to for children being admitted. Perhaps we don't always think about everything to do with dignity, particularly when it comes to children. Although we think we do, I'm not sure we always do.
Jo Birrell, Senior Clinical Nurse at Addenbrooke's Hospital in Cambridge. I was working on a ward for older people. There was one particular gentleman who was obviously very unwell, very short of breath, clearly reaching the end of his life. And in the course of looking after him, I realised that part of his agitation was he wanted to wear his dentures, but they weren't fitting. He didn't have any fixative in his soap bag. He didn't have any family that I could contact to bring some in. So I searched around the department, assuming that we'd have this, found that we didn't, went down to the hospital shop, assuming that the hospital shop would have it. They didn't have it. So I had to resolve the situation by going to the late night Tesco's and getting some for him. For me, this was a bit of an eye-opening moment because whilst we spend a lot of time making sure that we look after people's teeth, making sure we've got toothbrushes, etc., we actually haven't got the fixative that keeps the teeth in for some patients, so we now have it as a stock item.
I'm Richard Mackay, I'm the charge nurse and I work in Ward 50 in the Western General Hospital in Edinburgh, and it's for acute elderly medicine. We've been using emotional touch dials to get patients and relative stories. How it works is we have various words written down like coming into hospital, visiting time, meal times, and we invite the patient or relative to talk about how they feel during these times and to pick a word that best describes that, both positive and negative. We have a wide range of words from happy, sad, frightened, delighted. One of the stories was from a relative. His mum was an elderly lady and she suffered from dementia. And when he came in to visit her, she was needing to go to the toilet. So he approached one of the nurses. The nurse asked, would you like to assist your mum to use the toilet? And he says, yes, of course, that's fine. I normally help at home. So the nurse pulled the screen and helped the patient stand up and pulled the lady's underwear down in front of her son. Now, his son was really shocked by that as he wasn't expecting it. He was expecting her just to walk her through to the toilet. And he really felt his mum felt belittled by this. The next day he came in at visiting time again in the afternoon and his mum needed the toilet. So again he called the nurses and says, would you like to help my mum to the toilet? This time he stood outside the room and he listened to the nurses talking to his mum, and he felt that the nurses really engaged at her level. And his mum was busy telling him a story that they had probably heard 7 or 8 times already, but they reacted as if it was the first time they heard it, and that felt really good for him. For me as a manager, it's really beneficial to actually get the whole story from a patient and share it with the staff, because we're hearing the positives and negatives about the patient's journey. We're learning from this the things that we do well and obviously trying to promote that within the ward. And obviously the things that we don't do so well, we've obviously got to tackle them as well. Very often in the NHS where the feedback that we get is negative feedback, so mixing the positive with the negative is going down very well.
I'm Jim Blair, Senior Lecturer in Learning Disabilities at St George's, University of London and Kingston University. It was a few weeks ago now, about a month and a bit ago, was that a mother of 2 severely learning disabled children rang me up to tell me about a friend of hers that has a learning disability and Down syndrome, who's on one of the wards at St George's Hospital in Tooting. And she was worried about the staff being able to support this person adequately and appropriately to meet her needs. So what I said I would do is I would ring up the community nursing team. I rang up and I spoke to Louise. Louise is a community learning disability nurse, and what I asked of her was that if she'd go in and see this person and take with her a hospital passport and fill it out with the staff that are there, as well as obviously primarily with the individual and anybody else that knows her well. And during this time when they were talking together, they found out that she was frightened of the dark. Now, being frightened of the dark is not very helpful when you're on a ward, because the lights go out at night, understandably, for everybody else to go to sleep, but for this person, it would have been a disaster. It would have meant a distressing, anxiety-provoking, and a fearful time. What did they do about this fear of the dark? The way around it was getting a bedside light by her bed, turning it on, which she did before the lights went off. When the lights went off, she already had a light on, so she was never in the dark. And the other thing that she liked was she likes Elvis. It meant that staff, who now know that she likes Elvis, when they were talking to her before doing things like blood pressure, pulse, or anything else, they could talk to her about Elvis. So to put her at ease, make her feel relaxed, because no one really likes having procedures done to them. And this is a way of making it easier for everybody. 2 small, very small things happened to change what could have been a very difficult situation for everybody. It meant that she had tailored care that she specifically required that reduced her anxiety and distress, and also made for a better stay for her and a better stay for the staff and for everybody. Small changes made a big difference.
My name is Mrs. Martha Machai. I work at Green Hill Nursing Home. I'm a clinical leader in a dementia unit. On the floor which I work, it's a 22-bedded floor. We've got 5 carers working in the morning and 5 carers in the afternoon. We also have 2 dining rooms on the unit. Before, we used to actually mix the residents who needed to be assisted with meals with the ones who needed minimal supervision, resulting in 2 carers maybe looking after at least 10 residents. We encountered problems of interrupted meal times, safety issues, and also some of the residents having their meals when they were called and after waiting for a long time. After identifying these problems, we actually decided as the team to identify the residents who needed to be assisted and separate them from the ones who needed minimal supervision. We also agreed that during the serving of the main meal for the residents who needed minimal supervision, 2 carers will be based in that dining room. But after the serving of the meals, only 1 carer will remain supervising and encouraging the residents, and the other carer would join the other 3 who were in the other dining room where residents need assistance with their meals. The residents now have a more dignified experience because their meal times are uninterrupted, they are safe, and they actually have the meals served at the right temperature and unhurriedly.
My name's Jo James and I'm the lead for the Dignifying Dementia Care project at Imperial, mostly based at St Mary's in Paddington. A&E is a bad place for people with dementia because It's too busy, it's too rushed, it's very frenetic, it's noisy. So we've redecorated a cubicle and we've kind of making a tranquil space, a place which we feel would make people feel, you know, less frightened, more in control of their environment. And it's got natural light, it's got nice pictures on the wall, it's got less medical equipment, a comfy chair, and it's a sort of tranquil place in a mad environment around the edges. And we're also we're improving the wayfinding to things like toilets, because there's nothing worse, you know, there's nothing more undignified really than not being able to find a toilet when you need one. We've trained a volunteer who's going to be doing one-to-one care of these people, who's going to be sitting with them, comforting them. We're training people in doing hand massage, the nurses, so that if somebody's very agitated, you can massage their hand. We're also obviously doing work on pain. We're looking at new ways of assessing pain, and there's a very good scale called the Abbey Pain Scale, which is for assessing pain in non-verbal patients with dementia. And we're bringing that in so that patients get an automatic assessment, and we work on probability. If it's obvious that something will be causing pain, then we should be addressing that and we should be treating it. We shouldn't just wait for somebody to ask who can't ask. We're also looking at interesting modes of delivery for pain relief. We're looking at not just thinking we have to stick something in an injection. We're looking at lollipops, at patches, and things like that, which are, you know, a much better way of delivering pain relief for this group. And we're also looking at how we manage procedures. It's quite frightening having a drip put in you or blood taken if you don't really understand the rationale behind it, and also if you can't anticipate the pain. So we started using an anaesthetic gel, which we put on in advance so that the person won't actually feel the needle going in, because it's an incredibly undignified struggle when somebody's frightened of what you're trying to do. But also teaching the nurses to approach it in a different way, to approach the patient, to establish trust, to spend a little bit of time and to do some distraction techniques with them as well so they don't get quite so agitated. And so those are some of the areas we're covering in the A&E department at the moment. Our ultimate plan is to make the trust a dementia-friendly trust where people actually think, yes, this would be a good place to come and we're not going to be frightened of coming in. And there's a lot of work going on in the care of older people's wards, in the medical wards and surgical wards as well, which mirrors what's going on in A&E. And ultimately, I'm hoping it'll all kind of spread round and everybody will be, you know, adhering to the same standard. And then we'll have got where we need to be, really.